Much like the previous section, this lecture on the evaluation and management of trauma patients is definitely one of the most high-yield topics on the surgery section of your exam, and as such, we will go into some depth. We'll start with the abdomen, and one thing I immediately want to stress about abdominal injuries is that the patient does not have to be complaining of pain for a serious injury to be present. The test makers love to exploit this fact by describing a patient who feels pretty good after a traumatic event. It has a life-threatening injury that you will only detect by completing a thorough workup. After that, we will discuss thoracic trauma and pelvic trauma. Let's start by talking about penetrating trauma. Bullets, by their very nature, are designed to explode upon impact and splinter into many pieces, which significantly raises the risk that a fragment will perforate the bowel. Anytime there is a hole in the bowel, it must be repaired, so if asked about the management of any abdominal gunshot wound, the answer is always an exploratory laparotomy. Conversely, stab wounds do not necessarily perforate the bowel. Thus, surgery can be avoided in many situations. The first step in evaluating these patients is to consider the vital signs. If they have normal heart rate and blood pressure, they likely aren't hemorrhaging, and you can use an ultrasound fast scan to look for the presence of blood in the abdominal cavity. However, if they are hemodynamically unstable, an artery has probably been nicked and open surgery is necessary to stop the bleed. Diaphragmatic rupture is a relatively rare occurrence in trauma patients, but is commonly tested due to the unique factors involved in the injury. Rupture can result from either direct perforation from penetrating trauma or as a result of increased abdominal pressure after sudden onset blunt trauma like a high-speed motor vehicle collision. The reason it occurs more frequently on the left side is that the liver generally protects the right hemidiaphragm from rupturing. As you can imagine, with any diaphragmatic injury, breathing is impaired. Magnifying this respiratory distress is the fact that the abdominal viscera are able to herniate into the thoracic cavity and can actually compress the lungs. For this reason, respiratory distress is the most obvious symptom of these patients on presentation. The patient may also complain of left shoulder pain, which is a result of referred pain from the inflamed diaphragm. Note that this same referred pain pattern occurs with splenic pathology. The diagnosis is most easily made from noting evidence of loops of bowel in the thoracic cavity on X-ray, as can be appreciated on the next slide. Note the absence of the entire left hemidiaphragm, as well as loops of bowel replacing the base of the left lung. Management of this condition requires surgical repair, but it is beyond the scope of this exam. The liver and the spleen are the two most commonly injured organs in the abdomen after blunt trauma. This is because of their proximity to the ribs, which break easily and damage the underlying structures, as well as the fact that both organs are surrounded by a firm capsule that can rupture with direct contact or a sudden increase in intra-abdominal pressure. Both organs are very vascular, especially the spleen, and thus severe liver or spleen injuries often present with patients in hemorrhagic shock with low blood pressures. As mentioned previously, irritation of the diaphragm causes referred pain to the shoulder, and since both of these organs are in contact with the diaphragm, if either becomes inflamed from injury, the patient will complain of shoulder pain. Left with splenic injury, right with liver. Traumatic pancreatic injuries are very serious and usually result from blunt trauma to the epigastric area. While a handlebar injury is the quote-unquote classic story for this condition, motor vehicle collisions or any other sort of high-speed blunt trauma to the epigastric area can result in pancreatic injury. The telltale sign on exam is Cullen's sign, which is the presence of a bruise in the umbilical region. Try to blaze this picture into your mind, because if they are testing blunt pancreatic trauma on your Step 2 CK exam, they will most likely use an image very similar to this one. Now here's the nice part about blunt abdominal trauma. Despite the fact that there are many unique injuries that can occur, each with their own constellation of signs and symptoms, the diagnosis and management algorithm is identical. So if the question stem asks about what the next step is in managing the patient, don't rack your brain thinking about the specific injury. In terms of diagnosis, a FAST scan is the test of choice for blunt abdominal trauma. The focused assessment with sonography for trauma, or FAST, is just an ultrasound exam that evaluates for the presence of blood in 4 different locations: the pericardial sac, the pelvis, the perisplenic recess on the left, and the hepatorenal recess on the right. If positive, meaning blood is present, the organ being evaluated will be surrounded by a dark, hypoechoic region as seen on the image to the right. This indicates an intraperitoneal bleed and requires further workup. If the FAST is negative, there are 2 specific indications to continue on to another imaging study, the CT. The first of which is concern for a splenic injury. Splenic rupture may not immediately result in a substantial bleed on initial exam, but can lead to late onset hemorrhage. So if you are concerned about splenic injury based on the symptoms we discussed above, and a FAST scan is negative, order a CT. The other situation in which a CT is helpful is if you are concerned about a retroperitoneal bleed, such as hemorrhagic pancreatitis, which we will discuss shortly, or a ruptured aortic aneurysm, which we discussed in the vascular section. Management of these patients requires assessment of blood pressure. If the patient is hemodynamically stable, you should take a wait-and-see approach with close monitoring and frequent exams, along with aggressive fluid resuscitation. However, if blood pressure is low, and on the test they will make it very obvious, something like 80/40, all blunt abdominal trauma patients get exploratory laparotomies to find the source of the bleed and stop it. Now let's tackle a case. A woman is jogging at night and gets hit by a car. She has severe abdominal pain that radiates to the back. Vital signs are stable and the patient is admitted for evaluation. 3 days later, the following picture is taken. What is the most likely diagnosis in this case? A. Pancreatic pseudocyst. B. Hemorrhagic pancreatitis. C. Ruptured abdominal aortic aneurysm. D. Aortic dissection. E. Splenic rupture. The answer to this question is B. Hemorrhagic pancreatitis. In this condition, blunt abdominal trauma leads to vascular damage to the pancreas. The result is an uncommon form of pancreatitis. The telltale signs in this question are that the patient has pain radiating to the back, which should make you think pancreatitis, as well as the image showing bruising of the flank, which is also known as Gray-Turner's sign. Also, unlike in traumatic pancreas injury with the periumbilical bruising discussed above, bleeding in this condition is delayed. While pancreatic pseudocysts are a sequelae of pancreatitis, they don't occur until 6 to 8 weeks after the episode. With an abdominal aortic aneurysm, you would not expect the vital signs to be stable, as the intravascular volume would be significantly decreased. You might also expect to find a pulsatile mass on exam. Conversely, aortic dissections usually present with increased blood pressure, and the pain with dissections radiates to the back between the scapulas as opposed to being abdominal in origin. Finally, with a splenic rupture, you would expect to have left-sided referred shoulder pain. Furthermore, this patient's bruising is on the right side, the opposite side from the spleen. Now, let's move on to the types of thoracic trauma you will likely see on your Step 2 CK exam. Pneumothorax occurs when air enters the pleural cavity. As you may recall, the lungs require surface tension between the visceral pleural lining of the lungs and the pleural lining of the thoracic cavity to remain fully inflated. If something gets into the pleural space and disrupts that surface tension, the lung collapses. That's exactly what occurs in a pneumothorax. Air enters the pleural space and breaks the tension between the inner and outer pleural linings, causing the lung to collapse. While this air entering is often due to trauma, it can also occur spontaneously as well. Patients will complain of severe chest pain on the affected side, and since there is now air where there used to be lung tissue, the breath sounds will be decreased and the percussion will be hyperresonant because it's effectively like beating on an air-filled drum. An important aspect of the, quote, regular pneumothorax, as opposed to a tension pneumothorax, which will be discussed momentarily, is that as the lung collapses, it creates a relative vacuum on its side of the thoracic cavity, which pulls the trachea toward the affected side. Diagnosing a pneumothorax requires a chest X-ray, which shows the presence of a collapsed lung. Note on the image to the right the thin white line that the red arrows depict. This is actually the border of the collapsed lung, which is normally found all the way out at the edge of the thoracic cavity. Everything lateral to that line is now air as opposed to lung tissue. While it may be difficult to appreciate here, you can often see the loss of lung markings where the collapsed lung used to be. Treatment of this condition requires placing a chest tube, which acts to suction all of the free air out of the pleural space, and in so doing, reinflate the lung. While a pneumothorax is a serious condition, it is considerably more benign than its terrible counterpart, the tension pneumothorax, which is a life-threatening medical emergency and can kill a patient in seconds. Because of this, it is vital for every physician to recognize the telltale signs, and you will undoubtedly see at least one, if not multiple, questions on this topic on your exam. Much like a pneumothorax, a tension pneumothorax leads to collapse of a lung by allowing air into the pleural space and disrupting the surface tension that keeps the lung inflated. However, in the case of a tension pneumothorax, the traumatic lesion acts as a one-way valve in which air can enter the pleural space but cannot leave. This increase in pressure can compress vital structures such as the trachea and vena cava. As the image seen depicts, with each breath the patient takes, they are sucking more air into the thoracic cavity, but not letting any out. This results in a significant pressure buildup within the thoracic cavity, which has the ability to compress vital structures including the trachea, the contralateral lung, and the inferior vena cava. If severe enough, it can cut off the return of blood to the heart, killing the patient almost instantly. Note that the image on the left shows a second mechanism that can cause a tension pneumothorax, an injury to the trachea that allows air into the pleural space. Different mechanism, but the result is the same. Elevated pressures in the thoracic cavity compressing vital structures. Take some time later to come back and study this image so you can fully understand the pathophysiology of a tension pneumothorax. The symptoms of a tension pneumothorax are largely the same as a pneumothorax: pain, hyperresonance to percussion, and decreased breath sounds. However, there is one crucial difference. As opposed to acting like a vacuum and sucking the trachea toward the affected side, the tension pushes the trachea away from the affected side. This is a very important point and the key to differentiating these two conditions. While confirmatory diagnosis of a tension pneumothorax requires a chest X-ray, this is an absolutely emergent condition, and thus if you have suspicion that a tension pneumothorax is present, you must forego the X-ray to save time. Instead, if you suspect a tension pneumo based on the patient presentation, the first step in management is a needle thoracotomy, which involves placing a syringe into the pleural space to relieve the pressure that has built up. Once that's done, you can then get a chest X-ray and put in a chest tube, which is the definitive treatment for a tension pneumo. It may seem counterintuitive to stick a needle in someone's chest without an X-ray proving you are right, but in this case, it may save the patient's life. A similar condition to the pneumothorax is the hemothorax. While functionally a hemothorax results in the collapse of a lung as well, in this case it is blood, not air, responsible for disrupting the surface tension of the lung and leading to collapse. After a traumatic injury, any significant bleed into the pleural cavity can produce collapse. In this case, the patient will still complain of chest pain and breath sounds will still be absent, but instead of the hyperresonance to percussion, that results from a thoracic cavity filled with air, the patient will be dull to percussion because you are now tapping on a drum filled with blood. Diagnosis is again based on chest x-ray. Because fluid is gravity dependent, on an upright chest x-ray, the fluid will be found at the base of the thoracic cavity and is best appreciated by the blunting of the cosophrenic angles on an upright film. A CT scan may also be helpful in localizing the source of the bleed. Treatment of this condition requires placing a chest tube to drain the blood from the pleural cavity. Most of the time, the bleeding will stop itself and no other intervention is required. However, in certain cases, the bleeding will continue and a surgical thoracotomy is necessary to open the thoracic cavity and manually stop the hemorrhage. Note that while this is a very serious condition, it is not as emergent as a tension pneumothorax because the pressure does not become great enough to compress the vital structures. The left side of this image shows a severe hemothorax that has completely engulfed the left lobe of the lung, leading to a so-called whiteout appearance. A chest tube was placed on this patient, and several days later, you can see that much of the fluid has been removed. Topics of pneumothorax, tension pneumothorax, and hemothorax are incredibly high yield on this exam, so Kaplan created an algorithm to work through these cases. Memorize this and you will be in great shape for any questions they may throw at you on the exam. In brief, if the question stem describes a patient with sudden onset chest pain and shortness of breath after a traumatic event, the first thing you should do is look for something in the stem about the results of percussion. If the patient was dull to percussion, you can be certain that you were dealing with a hemothorax. Get a chest x-ray and then place a chest tube. Conversely, if the patient is hyperresonant to percussion, the next thing to consider is the trachea. If the stem tells you the trachea is deviated toward the side of the affected lung, you know you are dealing with a vacuum caused by the less emergent pneumothorax and have time to get a chest x-ray to confirm your diagnosis and place a chest tube. However, if the trachea deviates away from the affected lung, it means that the air buildup on that side is not only pushing the trachea to the opposite side, but is also compressing vital structures like the inferior vena cava. This patient could code at any second, so you must forego a chest x-ray and a chest tube, both of which take time, and instead perform an emergent needle thoracotomy to relieve the pressure that has built up in the chest. The final topic we will discuss in this lecture is pericardial tamponade. In this condition, blood fills the pericardial sac, the fibrous structure that surrounds the heart. If enough blood enters this space without being able to escape, it leads to progressively increased pressure on the heart within the sac, making it more difficult for the heart to perform its pumping function. In many ways, it is synonymous with a tension pneumothorax. Pressure builds in a closed space, leading to compression of blood flow, and must be released quickly or it can be life-threatening. Most commonly, the bleeding in the pericardial sac is a result of trauma to the anterior chest wall, either secondary to a broken rib that punctures the sac and causes bleeding, or via direct penetrating trauma. The classic symptoms of this condition result from the fact that the heart is unable to pump efficiently when it is being compressed by fluid in the sac. Thus, blood backs up into the venous system, causing jugular venous distension. The cardiac output decreases, and thus so does the blood pressure. Heart sounds are decreased because you are listening through an additional layer of fluid. If you suspect pericardial tamponade as the cause of a patient's presentation, the immediate next step is to get an EKG. The classic finding on EKG is called electrical alternans and can be seen in the V4 lead at the top right of this EKG. In electrical alternans, the heart is effectively bobbing or swaying back and forth in the fluid-overloaded pericardial sac. As such, the magnitude of the QRS complex alternates with each beat, small on one, large on the next, back to small on the third. This finding is pathognomonic for pericardial tamponade. While an EKG is the fastest test to diagnose tamponade, the diagnostic test of choice is an echocardiogram, which can show the presence of fluid in the pericardial sac. The treatment of this condition requires an emergent pericardiocentesis, in which a needle is placed in the pericardial sac to drain the fluid that has built up and relieve pressure on the heart. Let's finish our discussion of trauma with two high-yield cases. First, a guy suffers a blow to the chest with a baseball bat. He is brought to the ED with right-sided chest pain and dyspnea. He is tachypnic and tachycardic and has decreased breath sounds on the right and left tracheal deviation. What is the next step in the management of this patient? Is it A, a pericardiocentesis, B, a chest x-ray, C, a needle thoracotomy, D, chest tube placement, or E, an EKG? Now, not to beat a dead horse, but this patient is presenting with all the telltale symptoms of a tension pneumothorax and needs an emergent needle thoracotomy to save his life. Again, the key sign here is that the trachea is deviating away from the side of injury, indicating that the pressure is building on the right and needs to be released immediately. This is not a case of tamponade, so pericardiocentesis would not be warranted. While chest x-ray and chest tubes are both indicated later in the treatment of the patient, they are both too slow to be completed in the emergent care of this condition. This patient's symptoms are not due to cardiac disease, so an EKG is not warranted in this patient. Great work. Now let's move on to one more question on a subject we have not yet covered. A 14-year-old boy crashes his bike and falls directly onto the central bar. He comes in with severe groin pain and swelling. Exam reveals blood at the urethral meatus and a high-riding prostate. What is the next appropriate step in the management of this patient? Is it A, placing a Foley, B, getting a retrograde urethrogram, C, empiric antibiotics, D, a CBC and electrolytes, or E, reassurance? This is a classic case of urethral trauma, and the key buzzword guiding your management is that the patient has blood at the urethral meatus. This bleeding is caused by trauma to the urethra, likely at the level of the prostate where the blunt trauma occurred. The important consideration here is that this patient might have a severe urethral injury in which urine outflow is blocked, and you must assess that with a retrograde urethrogram. In this procedure, radio-opaque dye is inserted at the urethral meatus, and then an abdominal x-ray is taken to ensure that the urethra is patent and that the dye can freely travel all the way to the bladder. If the dye cannot, it is indicative of a damaged urethra that must be surgically repaired. Note that you would not want to stick a Foley catheter into a damaged or obstructed urethra because you risk making the injury worse. You must assess patency, however, which is why answers C, D, and E are incorrect. This is a classic Step 2 CK question, one that you are very likely to see on your exam. Okay, that's it for today's lecture. Next time we will be discussing the surgical abdomen.